Okay, we're going to start with the, well, it's a right shoulder protocol. First thing we're going to do is go through the protocol and learn a little bit of anatomy. I'm going to go in a transverse biceps plane, and then I'm going to go in a long axis of the biceps plane. And then after that, then I'm going to actually take the probe in transverse. I'm going to externally rotate his hand about 35 to 40 degrees, and then I will then slide over to the coracoid and get the coracoid process. I'll then pivot the probe off the coracoid toward the acromion to look at the coracoacromial ligament. After I've done that, I'll come back down and pivot back down over the coracoid, drop below the coracoid, and then do a long axis linear slide over to the left tuberosity where the subscapularis inserts. Once I see the subscapularis and longitudinal, then I'm actually going to slide back and pivot the probe slightly up toward the coracoid, and then internally rotate to look for subcoracoid impingement of the subscapularis as well as the biceps to the coracoid itself. Once I've actually done that, then I'm actually going to level the probe back off on the subscapularis longitudinally, and then I'm going to actually just internally rotate and externally rotate to see the subscap insertion move. Once I've done that, then I'm going to turn the probe transverse to the subscapularis, and when I do that, I'm going to then have to pivot the probe or tilt the probe toward the axis of the shoulder itself so that I can line up on the subscap, the three heads of the subscapularis inserting on the lesser tuberosity. Once I see the three heads of the subscapularis tendon insertion on the lesser tuberosity and the cortex extending down the humerus, then I'm going to internally rotate, and as I do that, I'll see the lesser tuberosity, and then I'll see the biceps longitudinal in the groove. I'll externally rotate to the lesser tuberosity, and then I'll see the subscapularis, all three bundles in transverse. Once I'm done with that, then I'm going to actually go to the next compartment. I would call that the anterior compartment, and then I will actually do an AC joint in crossed arm test on the AC joint and look for any instability or imbrication of the AC joint. But what I want to do first is I'll actually say that you're going to find the AC joint by palpating the clavicle and the scapula, feeling the soft tissue till you see the meat. That will be the AC joint itself. Then you put the probe in front of your finger, leaving your finger there to see the AC joint. Once you've got the AC joint under the probe, then you can do a crossed arm test, and as you do that, he brings his elbow up to stress it. The most important part is to lock the probe down so that the probe does not move as you crossed arm and do the stress test. After you've done the AC joint stress test, then you can actually then slide linearly across the acromion toward the elbow so that you see the supraspinatus insert on to less tuberosity between the humerus in the acromion itself. And then once you see that bird's beak appearance exiting underneath the acromion, we're going to do straight abduction along the axis of the probe to see if they've got subacromial impingement. The normal distance between the acromion and the humerus is 10 millimeters, and it should continue to stay the same in the glenoid. It should not rise. If the deltoid is now winning and rising the humerus, you then get impingement. Then I want to add a abduction and flexion. I'll move the probe into abduction and flexion, and then I will then do the same thing with some flexion to see if he has any impingement with flexion added. Both of those measurements should still stay the same no matter what, in neutral as well as with abduction and flexion or with abduction, and 8 to 10 millimeters is the normal distance. One of the things I just remembered also is the first image of the transverse biceps that I see in the groove. Many times I think it's important to go down to the pec major insertion and maybe even slide over to the deltoid insertion and look for those pathologies. But when you get to the biceps and you come up to the groove, what I'll do is you tell them to lift up on your hand to stress the biceps. And when you do that, then you can see whether the biceps either subluxates medially or actually even dislocates medially. The long head of the biceps wants to go home to the short head of the biceps, so it always goes medially. Now back to the protocol. So after we've done the biceps transverse and long, and we've done the coracoacromial ligament and the subscap long and the subscap transverse, then we do the AC joint, we do the subacromial impingement view and with flexion. Then we go into the rotator cuff. So we go into back pocket position, elbows tight to the body, and if they can't get into that position, then you just have them drop their arm to their side, internally rotate them. But most of the time, even though they hurt, the active pain is what hurts. So what I do is I say, just let me do it. And if you passively bring their arm up, they don't usually have the pain. And coming out of that, same thing. If you want to come out of that position, just say, don't help me, and you do it, because active pain is when they usually hurt with rotator cuff. Once you're in this position, then you take the probe and you point it toward their belly button, and this is a long axis view of the rotator cuff, or the supraspinatus, the infraspinatus, and the teres minor. Supraspinatus, the infraspinatus, and the teres minor. So we're going to inspect all three of those, and then when we're done doing that, we're then going to go transverse. We're going to point the probe toward his eyes or his nose, and now we're going to see the supraspinatus, infraspinatus, and teres minor in transverse, or three tendons with septums in between them, and actually central tendon septums as well. So you'll see what we call a wagon wheel appearance of the transverse rotator cuff, supraspinatus, infraspinatus, and teres minor. After we're done with those two, and those actually are the gold standard views for rotator cuff in the world, then we're going to actually put this hand in the hip, thumb back, a little Marilyn Monroe is what I say. And then what I would like you to do is to remember that we want to see the biceps in transverse. We keep the elbow back so we can expose the shoulder, but we want to see biceps transverse. Once we see the biceps transverse, then we're going to come up and do a little pivot move, about 15 degrees max, to see the rotator cuff interval. The rotator cuff interval is the biceps with the supraspinatus and the subscapularis on the other side. So subscap and supraspinatus and biceps here. Between the supraspinatus and the biceps is the superior glenohumeral ligament, and between the subscapularis and the biceps is the coracohumeral ligament. And those two ligaments and the transverse ligament become what's called the rotator cuff sling, and supraspinatus, superior glenohumeral ligament, transverse ligament, coracohumeral ligament, subscapularis become the rotator cuff interval. 90% of all rotator cuff tears are in the 2.5 centimeter distance between the biceps and the supraspinatus. This is the critical zone, and this is the exact same image that a sagittal oblique view of an MRI gives the surgeon his idea where the tear is in relation to the biceps. The last view is hand on the stomach, and I'm now gonna do the posterior glenohumeral joint. I'm gonna go in transverse to the humerus. I'm going to find the humeral head with cartilage over the top, and then I'm going to tilt down and look at the glenohumeral joint where I can see the labrum and the glenoid. So the glenoid, labrum, and then we've got the humeral head with cartilage. We have the infraspinatus over the top of all that, and the deltoid, and then skin and fat. And so then once we see that labrum, then we can do internal and external rotation. As we externally rotate, we can see what's called a internal rotation or impingement or posterior impingement, and we may even see what we see is what's called a reverse Bankart's lesion, where they have a defect in the undersurface of the infraspinatus as it inserts onto the greater tuberosity. So that would be with the 12L probe. And then what I'll do is I'm going to switch to the 4C probe, the bigger, deeper probe, so that we can get a little better penetration and look at that joint and do the same exact maneuver. And that's because when we get to glenohumeral joint injections, that would be the easiest way to actually do a posterior glenohumeral joint injection. After that, we would move over to the glenoid, pivot slightly toward the head, and then we would look at the infraspinal glenoid notch where the suprascapular nerve lies with the artery. And then if we actually externally rotate, we'll see a venous plexus open up and close in the infraspinal glenoid notch where the suprascapular nerve lives.